Hi, my name is Mirvat Alasnag. I'm an interventional cardiologist in Jeddah, Saudi Arabia. I'm also a member of the USC Review for Radcliffe Cardiology, and I'm on the Sky Board of Trustees and editorial board for PCR Online. And so naturally, coming to the American College of Cardiology's 22nd 2022 conference, I focused a lot on the interventional trials. But it was also an opportunity for me to meet my colleagues and have some committee meetings and council meetings, particularly with respect to women in cardiology and future projects to establish heart centers, etc. But if we go back to the late-breaking clinical trials that we saw, an important one that caught my attention was actually not an interventional trial, but it was the sodium heart failure trial. And the reason it caught my attention is because we all have to treat heart failure patients. There are just simply not enough heart failure specialists around the world. And we tend to focus on the therapies and interventions for heart failure, particularly with a lot of the data that has come out in the last couple of years with the four pillars for treatment and so on. And it was important to look at sodium restriction and see how that impacts outcomes and how that also impacts quality of life in the patients. And interestingly enough, the results were very positive. It was a pragmatic trial. The authors or the investigators did not want to test urinary sodium. They wanted to see dietary restrictions and their impact. And so to me, that made a lot of sense. Other trials that came out actually were the GHATI trial. This was presented today. This was a part of the ACC Global Quality Solutions. And what it does is it looked at the quality parameters in the CAF PCI, formerly known as CAF PCI, but rather chest pain MI NCDR registry. And it really enrolled a large number of patients across the globe. And it was important to capture these data sets and kind of evaluate how we're adhering to guidelines, door to balloon times, door to needle times, etc., and to see that these are sustained compliance, and to see improvement in delivery of care and outcomes, and to also capture how we are doing with certain populations across the globe, in particular women. Trials that were discussed more today included the SURTAVI trial, 5 years outcome. This was very important because we do come from a part of the world, or I practice in the Middle East, where our patient population is actually very small. And so we do see a lot of small annuli. And this looked at self-expanding TAVR valves. The most important determinant of valve degeneration and deterioration was, in fact, small annuli. Larger annuli were less related to valve degeneration, along with men and patients with prior PCI, women and prior atrial fibrillation were actually associated with more rapid deterioration. So I think this goes back to lifetime management and how we select our patients, appropriate patients for TAVR. Another trial that was presented today again from China was actually the FLAVOUR trial. There's been a lot of discussion about the role of physiology, particularly with FLAVOUR MI and Ripcord 2 and so on that came out in the last few years. And you know, as every cath lab needs to have intracoronary imaging and needs to have intracoronary physiology. And this was a great trial that actually showed us that PCI guided by IVUS and PCI guided by FFR had similar outcomes in terms of myocardial infarctions and revascularizations. It begs the question to how do we define complete revascularization, particularly in patients with diffuse disease? But what it ultimately says is that there's an equipoise between both strategies, and ultimately it means that every cath lab should hold both technologies, perhaps physiology to tell us which lesions to treat, and then imaging to help us optimize the treatment should we choose percutaneous revascularization. And finally, the last trial that I think a lot of interventional cardiologists would be interested in is actually the DAPT Tabby trial, which was again presented today. And this trial looked at edoxaban and DAPT and looking at HALT, which is hyperattenuation and leaflet thrombosis. And we did publish our paper at US Review on that. And it was a single center trial looking at the role of antiplatelets in our patients in the Middle East. Nevertheless, this was a larger trial, obviously, and what they did is they looked at those who received dual antiplatelets and those who had a direct oral anticoagulant. Naturally, fewer Holt events were noted in the edoxaban arm, but there were no significant differences in terms of brain MRI, in terms of neurocognitive dysfunction, and so on, which probably means our default should still be antiplatelet therapy as opposed to NOAC, because we did see in other trials such as the Galileo trial and so on, where yes, there was a reduction in Holt, but the clinical correlation remained poor. The event rates were higher in Galileo, and hence it was terminated early, where patients had higher bleeding rates, but they also had other thrombotic events. So I think for now, this trial confirms current practice where most operators will be using antiplatelet therapy. So I'm hoping in this very brief summary, we capture the most important interventional trials for this year at ACC 2022.